Hello and welcome to Chapter 10, Respiration and Artificial Ventilation. We're going to cover the physiology and pathophysiology, positive pressure ventilation, which is our BVMs, maybe some CPAP and BiPAP, oxygen therapy, special considerations, and then assisting with advanced airways. So the physiology and pathophysiology. So mechanics of breathing. When we talk about ventilation, it's the process of moving air in and out of the body. Okay, that's our inhalation, our exhalation, and inhalation is that active process where the muscles expand and the size of the chest increases, and it creates a negative pressure inside the air. Or inside the chest cavity to create air pulling into the lungs. Okay. Exhalation is a passive process. The muscles relax, the size of the chest decreases, and it creates a positive pressure to push the air out. Okay. Tidal volume and minute volume. So tidal volume is the amount of air moved into and out of the lungs in one breath. Okay. Minute volume is the amount of air moved into and out of the lungs in 1 minute. Okay. We also have dead air space. So dead air space is the air moved in ventilation not reaching the alveoli. Everybody has about 150 mLs, give or take, of dead air space. Alveolar ventilation is the air actually reaching the alveoli, how much air is actually reaching down to the alveoli. Diffusion is that movement of gases from high concentration to low concentration. External respiration is the diffusion of oxygen and carbon dioxide outside of the body. So that's that breath that I take in when I breathe out. The air that breathes out of my mouth or nose releases the carbon dioxide, and then when I breathe in my mouth or nose, that's the oxygen that comes in. With internal respiration, that's where the gases exchange between the blood and the cells. Okay. Cellular respiration. This is the oxygen and carbon dioxide get exchanged into the blood cells. So, mechanics of breathing can get disrupted. The gas exchange can be interrupted, and it can also cause circulation issues. We'll look at some of those things. Okay. So respiration, adequate versus inadequate. So the brain and the body need a steady supply of oxygen to maintain homeostasis and to maintain function. When there is the low oxygen in the cells, we have hypoxia. Carbon dioxide must be continually removed as well. If it's not, then what we get is hypercapnia, and that's just that high level of carbon dioxide. We have to assess how well the cardiopulmonary system is accomplishing oxygenation and carbon dioxide removal. To do that, we look at how well they're breathing. Okay, we look at signs and symptoms of adequate and inadequate breathing, and we look at various different things in the body. Okay, compensation for hypoxia or hypercapnia is predictable. In order for the body to compensate, what it does is we get shortness of breath, we get an increased respiratory rate and depth, and increased heart rate. Okay, even though the body's saying, "Hey, something's wrong, we need to fix it," we can't have these things going on. We have to help the body fix these things, and that's what we're there to do. Okay. So early on, the steps of adjustment can meet the needs of the body despite the respiratory challenge. What that means is early on, the body can say, hey, I need to, have some shortness of breath, or I need to start breathing faster or slower to try and compensate for whatever is going on. Okay? It can't do that long term, though. It has to, something has to change in the body, because the body and the lungs, the respiratory system can't handle that for very long. Okay? Respiratory distress is when the body is compensating for a respiratory challenge and meeting the metabolic needs. Okay, so it's still meeting the cell's needs for oxygen. It's still meeting the cell's needs for carbon dioxide, even though it may be hypercapnic or hypoxic. It's still meeting those basic sustenance needs to maintain their function. Inadequate breathing. This occurs when challenged, when the challenges are too great for the body's compensation mechanisms. This is also known as respiratory failure. It's exceptionally important to recognize and often a precursor to respiratory arrest. When we look at respiratory failure, I kind of always think of, how well my SpO2 is going, my pulse ox. So if I've got a pulse ox of less than, 87, 86, then I'm probably getting into respiratory distress and even starting to get into failure. And also looking at my patient, how is their work of breathing? How difficult is it for them to take a breath? How easy is it for them to take a breath? All of those things tie into respiratory failure. So respiratory distress usually involves accessory muscle use, increased work of breathing. This patient is in severe respiratory distress. If she doesn't get fixed right away, what's going to happen is that she's going to go into respiratory failure and possibly even respiratory arrest. Okay? So, we need to know what's normal. Okay? So, signs of adequate breathing include normal mental status, normal pulse ox reading, so anything above 94 is normal. Okay? And normal skin color. Okay? Pink, warm, and dry. That pink status is what we want to see in patients. If they start turning other colors, then we need to be worried. Okay? So, signs of inadequate breathing include chest movements that are absent, abnormal, or uneven, abdominal breathing, area that can't be felt or heard, breath sounds that are diminished, wheezing, snoring, gurgling, stridor, gasping, anything like that. Some more signs of inadequate breathing. Their breathing is too rapid or too slow. Their breathing is shallow or very deep. Or it appears labored. Okay? Cyanosis, which is the bluish color of the skin. Inspirations or expirations are prolonged. So retractions and nasal flaring are especially signs of inadequate breathing in children. And that low oxygen saturation reading, less than, it says 95, AHA, and pretty much anybody that you talk to right now is going to tell you about 94%. Okay? So let's talk about hypoxia. The major causes of hypoxia is patient trapped in a fire, patient has emphysema. With a fire, when we think about the fire, think about what's going on in that fire. Okay, so we've got smoke, we've got heavy smoke, and it's killing all of the oxygen. That fire is also consuming all of that oxygen in that fire. Okay, emphysema, overdoses on a drug that has depressing effect on the respiratory system, such as any kind of opiate, fentanyl, morphine, Versed, any kind of drug like that causes respiratory depression. And then the patient having a heart attack. Okay, so what happens in a heart attack is the cells of the muscle are dying in the heart. Okay, there's a blockage in an artery. That artery can't flow blood to the rest of that heart where that infarct is, or that those dying muscular cells are. So what happens is those cells become hypoxic. So for inadequate breathing, we want to provide artificial ventilation to the non-breathing patient and the patient with inadequate breathing. Provide supplemental oxygen to the breathing patient. All right. So how do we know when to intervene? You really want to look at your patient. The more you see respiratory distress, the more you see respiratory failure, the more you see just difficulty breathing in general, you will begin to know when you need to intervene in your patient. So sometimes the respiratory failure patient can be breathing unconscious. So how do we know when to intervene? You know, you've got to look at your patient. You've got to be able to identify the adequacy of their breathing. If their breathing is inadequate, then yeah, it's probably time to start intervening. Okay. Airway. We talked about airway in the last lecture. Airway is a big one. We've got to make sure that we are always assessing that airway, just as we're always assessing breathing. It's a continual thing. We've got to, continuously check those things. So, things to think about. Okay, so what signs might identify the need to intervene in a breathing patient? Okay, so cyanosis is one of those signs. It's one of those big signs. Not every patient will have cyanosis, though, until they're probably in the respiratory failure, almost to arrest stage. So at that point, you should have been intervening if you hadn't already before that. So other signs would be the cyanosis, the difficulty breathing. They're having, they're having a hard time they have a hard work of breathing. Okay, so when we look at all of those things and we put it all together and we say, hey, we need to intervene, we need to do something right now. Okay, so positive pressure ventilation. This is forcing air or oxygen into the lungs when a patient has stopped breathing or has inadequate breathing. Uses force exactly opposite of how the body normally works to draw air into the lungs. So basically we're going to take a big bag and we're going to start forcing air into the lungs. Because the patient can no longer compensate, the patient can no longer do what it needs to do to compensate and correct whatever is wrong with the body. Okay, so some of the negative side effects of positive pressure ventilation is decreasing the cardiac output, dropping the blood pressure, gastric distension, which is where we get air that's pushed into the stomach, causing aspiration, or it can cause aspiration, cause vomit to come up to the esophagus and into the mouth, which then causes aspiration, or hyperventilation, where and this is more towards the rescuer side, where we don't bag at the proper rate, and that patient that now becomes hyperventilated, and we don't necessarily want that. Okay, so some techniques of artificial ventilation. Don't ventilate your patient who has vomiting or vomitus in the airway. When we do that, we're just forcing all of that vomit to go into the lungs, causing them to aspirate. We don't want that. We don't want to harm our patient like that. So we're going to suction. Just suction all that vomit out, and then start bagging them again. Okay. Watch for chest rise and fall with each ventilation. Ensure that the rate is of ventilation is sufficient for that patient. Make sure that they can see that patient and know that they are ventilating their patient sufficiently. Okay. Carefully assess the adequacy of respiration. How well is it going? Is it easy to bag? Is it too hard to bag? Do you think that there's something blocking the airway, or that the lungs are too constricted and too tight for breathing? Okay. If the patient is conscious, we're going to explain the procedure to them. We're going to tell them, hey, I'm going to put this mask over your face. We're going to start bagging you just to help you breathe. We're going to place it over the patient's mouth and nose. And then after the sealing on the patient's face, if they're conscious, we're going to squeeze the bag with the patient's inhalation or unconscious. If they're gasping, that means that their breathing is not adequate, and we're just going to take over breathing for them without regard to them actually breathing at like 8 times a minute. We're going to just ignore that and just start bagging them like we normally would, because that 8 times a minute is not sufficient to maintain anything. Okay, but if they are breathing like they're breathing too fast, or they're breathing just a tad bit too slow, then what we're going to do is we're just going to bag them with their breath. Try and get them to slow down if they're breathing too fast. Okay. So CPAP and BiPAP, we'll go over this in skills when you do the skill session. But for CPAP and BiPAP, these are forms of non-invasive positive pressure ventilation. CPAP is continuous airway positive pressure ventilation, and BiPAP is the biphasic positive airway pressure. So what we're doing in both of these things is we're putting a mask. We're making sure that the mask is sealed. We are making sure that when that patient becomes that CHF patient that has fluid in the lungs, what we're doing essentially is trying to force all of that liquid and all of that fluid outside of the lungs and outside of the alveoli. Okay, so we're talking. We talked about this a little bit in the last lecture, and we'll just kind of skim over it. This is in your CPR stuff too, so we'll go over it. Okay, so mouth to mask ventilation, used with a mask and a one-way valve. Okay, I'm not going to go through the skills. These skills are in the later on down. If you look down on the left-hand side, you can see that the skills are down there. They're all in one file as a PowerPoint skills section, and it goes step by step. It shows you the pictures and how to do it. Okay. So a BVM, or a bag valve mask, or a bag, whatever you want to call it. It's a handheld ventilation device. It's used to ventilate the non-breathing patient and or the patient in respiratory failure or arrest. Okay, this is that BVM again. This was in your CPR class, and it's also down there in the skills. Okay. It has a self-refilling shell that's easily cleaned and sterilized. However, these are one-time use. We do not, excuse me, when we use one on a patient, it's a one-time use thing. We do not re-sanitize it. We do not do anything with it. Another feature is that it has oxygen tubing to hook up to a oxygen tank, so that way we can put we put this on the patient at 15 liters 15 liters per minute, and this bag inflates, and it's just a reservoir, and we breathe that into the patient. Okay. So two rescuer CPR, two rescuer VVM is what the AHA strongly recommends. However, when we're on scene, we don't always get fire. We don't always get everybody like right then and there. So it's up to you to be able to do that one thing by yourself for the time being until more help gets there. Again, I'm going to skip through some of these things because of the fact that they're skills, and all of those skills can be looked at farther on down. And I'm a firm believer that it's hard to read off these skills and just expect you to know what they are without actually doing them. So we're just going to skip through some of those things, okay? So artificial ventilation of a stoma. A stoma is the hole in the neck, okay, down here. We're going to clear any kind of mucus plugs or secretions from the stoma. We're going to leave the head and neck in a neutral position because we don't need to move the tongue out of the way because we are bagging right there at the stoma. And use a pediatric size mask to establish a seal around the stoma. Okay, still the same way. We're just not we're not just bagging at the mouth. We're bagging at the stoma instead. So it's still the same rate, appropriate for the patient's age. And if unable to ventilate through the stoma, seal the stoma, and attempt to ventilate through the mouth and nose. Okay. So a flow-restricted oxygen-powered ventilation device, FROPVD. These are not something that we carry on the trucks anymore. They're out there, but it's just not something that we carry too much of anymore. Okay. They're only used on adults. The way they work is instead of you having to bag the patient, all you have to do is create the seal and hold it there, and it forces air into the lungs with the oxygen. Okay. So an automatic transport ventilator, we call these vents, we call these ventilators, whatever you're going to call it. It provides positive pressure ventilations. With these, we can adjust the rate and the volume, and the provider must assure appropriate respiratory rate and volume for the patient's size and condition. Okay, so this is an example of a transport ventilator. This is a very simplified ventilator. Here goes to the oxygen setup to supply the oxygen, and then these two go out to the bag, or to the tube, or however it's set up. You just turn these dials to the breaths per minute, how much tidal volume you want, and whether it's an adult or a child, and it sets it all up. Again, we have much more complicated ones out there. Mercy currently uses a Zoll impact vent that is completely digital. We set everything on that vent. So how would you decide which positive pressure delivery method to use for your patient? So some things to take into consideration is, what do you have in your truck? What's available to you? And what's the patient's condition? Because like if my patient's in respiratory failure or arrest, I'm going to use the bag valve mask. Or I'm going to intubate that patient and I'm going to start using a the vent. Okay, if my patient has CHF and that's why they have difficulty breathing, then I'm going to use the CPAP. Okay, for that patient. So it just kind of depends on what your patient is presenting with, how they're presenting, and how they, how hard their work of breathing is. Okay. All right. So oxygen therapy. So importance of supplemental oxygen. So we want to talk about the issues. Oxygen is a drug. It can cause harm. Over oxygenating our patients is a problem. We're finding out now, after years of placing everybody on oxygen at 15 liters non-rebreather, which is what I learned, we were harming our patients by over-oxygenating our patients. So oxygen should be administered based on your overall eval of the patient's presentation and any kind of possible underlying conditions. So you have to be cautious with oxygen. You don't want to give them too much oxygen, because then we can cause oxygen toxicity inside the lungs and inside the body, and the body just basically doesn't know what to do with all that oxygen, so it just kind of leaks out into the cell, out of the cells, and says, hey, I'm just going to float around here because I don't know what to do, so I'm just going to hang out here and cause all sorts of havoc in the body. Okay. So some equipment, we've got portable and installed equipment. These are portable tanks here, a D tank, and I think that's an L tank. It's a little bit bigger. We also have a regulator there with a key and various things to use. This is an M tank. They go up. This one actually has, looks like a mechanical system to pull the M tank. They are heavy, especially when they're full of oxygen. So it pulls out. You can take out your oxygen tank and put it back in. But this is a fixed tank, and it will last you for quite a while. Okay, we talked about it. So a D tank has 350 liters of oxygen. An E tank, which is that other one, not an L tank, has 625 liters of oxygen, and the M cylinder has 3,000 liters of oxygen. So about 10 times more than that D tank. And then of course we have G and H. Okay, so G has 5,300 liters of oxygen, and an H cylinder has 6,900 liters of oxygen. So they use pressure gauges, regulators, and tubing, all intended for use with oxygen. You don't want to use any kind of non-approved oxygen things, because if that happens and it occurs, oxygen is a flammable source, so it can, become a good fuel source for a fire. Non-ferrous wrenches. Ensure the valve seat inserts and gaskets are in good condition, and use medical grade oxygen. Okay. Open the valve of an oxygen cylinder fully, then close it half a turn to prevent someone else from thinking that the valve is closed and trying to force it open. Store these cylinders in a cool, ventilated room, properly secured in place. We don't want them falling down. We don't want them to do anything like that. And then have oxygen cylinders hydrostatically tested every 5 years. So yeah. Don't drop it. Don't leave it. Don't let it, set it up on a table and walk away, because it can fall. It can have disastrous effects. Basically what happens is if it's not secured, it's a missile, and it can go through concrete walls and various things. And then never allow smoking when you have the oxygen in use. Okay. No open flames, no grease or oil, fat-based soaps on the devices, adhesive tape on the cylinder. Never try to remove an oxygen tank by dragging or rolling it on its side or bottom. Just some things to be aware of. Okay. So pressure regulators connected to the oxygen cylinder to provide a safe working pressure of 30 to 70 psi. Flow meters. Okay, these allow the control of the flow in liters per minute. Low pressure flow meters are pressure compensated flow meter. It's a constant flow. High pressure flow meters are like a CPR device. Respirators and ventilators such as CPAP and BiPAP devices are also high pressure. Okay. These are flow meters. This is probably the one that you'll see the most of. This is like a 1980s version of the ones that we have now. So they don't have the big, instead of the big huge green cube around it, it's just a tube, a cylinder tube now. So you'll also see these are the most common regulators out there. It goes up to 2,000. This is for a pigtail, where you can attach like a hose to it. And then this is where your actual like nasal cannula or non-rebreather hooks up. So humidifiers, it's connected to the flow meter, to the regulator, and it just provides humidified air. We don't necessarily do this on the truck anymore unless the patient is already on it, like at home or at the hospital, nursing home, whatever. So we don't necessarily do that anymore, just in those cases. And it's more for patients who are on oxygen all the time, long-term type patients. So common hazards, okay. If the tank is punctured or if the valve breaks off, the supply tank can become a missile. Oxygen supports combustion. It can saturate towels, sheets, clothing. And oxygen and oil do not mix under pressure. Okay. In rare medical situations, oxygen toxicity or air sac collapse can be caused. Infant eye damage. We're pushing too much oxygen inside into the body. Okay. Respiratory depression or respiratory arrest. These are very rare to have occur with oxygen use. Okay. Again, we're gonna go through this when we go through the skills class. We'll go through all of the devices together, and we'll get you a chance to get hands-on with those things. So the non-rebreather mask, okay, is the best way to deliver oxygen in high flow to that patient. So we're talking 10 to 15 liters per minute with these, whereas like a nasal cannula, which we'll look at, you're looking at like 6 to 8 liters per minute, okay, or 2 to 6, okay, liters per minute on a nasal cannula. So with these, it has the bag here, this reservoir bag. You want to make sure that it's inflated before you actually put it on the patient. When you place it on the mask on your patient, we're going to place the strap around the head. We're going to tighten the strap, and then we're going to pinch the nose piece over the nose to make sure it's secure. Okay. So it provides oxygen at a rate of 80 to 100%. It's a new design that allows for one emergency port in the mask. to the patient so that they can still receive atmospheric air should the oxygen supply fail. So this right here allows for normal air to come in. So that way, just in case this is actually like created that seal around the mouth and nose, they're not going to like suffocate. Okay. It's the best choice for patient nasal cannula. Sorry. These are the best choice for a patient that refuses to wear an oxygen mask. Some patients feel claustrophobic, and when they put that mask on, they can really feel that claustrophobia come on, and they do not want that mask on. So a nasal cannula can work for them. It provides oxygen concentrations between 24 and 44%. Oxygen is delivered to the patient by two prongs that rest in the patient's nostrils, and should deliver no more than 4 to 6 liters per minute. 6 is probably your high end. You can go down as low as 2. So a partial rebreather mask, it's similar to a non-rebreather mask. There's no one-way valve in the opening to the reservoir bag, and it delivers 40 to 60% oxygen at 9 to 10 liters per minute. Okay. A Venturi mask, it delivers specific concentrations of oxygen by mixing the oxygen with inhaled air. Some have set percentages and flow rates. Others have adjustable Venturi ports. Okay. This is that Venturi mask. This is the port that we hook onto to provide the oxygen. Okay. So a tracheostomy mask. This is placed over the stoma or the tracheostomy tube to provide supplemental oxygen. Connected to 8 to 10 liters per minute of oxygen via supply tubing. Okay, this is that tracheostomy tube mask, and it just sets right over the stoma or the tracheostomy, and it provides oxygen. So some special considerations to take note of are facial injuries. Bleeding and swelling can disrupt the movement of air. Aggressive suction and advanced airway maneuvers may be necessary. Obstructions, foreign bodies can impede ventilation of patients. If unable to ventilate, always consider the possibility of an obstruction. Again, we talked about this in the last lecture. Dentures should ordinarily be left in place. Take them out. The only thing that it really does is provide a structure of the mouth. So in some ways I understand what they're getting at, but they're a choking hazard. They can be a choking hazard, so just taking them out is probably the best way to deal with those. Hypoxia often occurs rapidly in children. Children burn oxygen at twice the rate of adults, and it's accounted for by the many anatomical differences associated with the airway. Okay. For pediatric patients, when we're ventilating them, we want to avoid excessive pressure and volume. Use the properly sized face masks. Flow-restricted, oxygen-powered ventilation devices are contraindicated. Pediatric-sized non-breathers and nasal cannulas. Not every ambulance service has the pediatric-sized non-breather. So what we do is we just do blow-by for those patients, where we take like either an adult-sized mask and we place them. We just hold the mask up to their face. We don't actually put the mask on their face. And gastric distension may impair adequate ventilations. Again, that gastric distension is where we get air pushed inside the stomach and causes vomiting. Okay. So, assisting with advanced airway devices. These, what we're talking about is endotracheal intubation. They require direct visualization of the glottic opening, the vocal cords, and devices inserted blindly, meaning without having to look into the airway to insert the device. Okay. So to prepare the patient for ventilation or intubation, we're going to maximize the oxygenation prior to procedure. What some services are now doing is providing lots of oxygenation to that patient by placing them on a nasal cannula at like 25 liters per minute while you're doing the intubation. So that way we can make sure that we've got enough time to do the intubation. Place the patient in a sniffing position, which means that their head is kind of almost hyperextended but not quite. Cricoid pressure, if needed, is where we take and push down on the cricoid cartilage, or the Adam's apple, so that way it makes it just a little bit easier to direct, visualize the vocal cords and the epiglottic opening to get the tube in there. For confirmation, what we're going to do is we're going to place that patient on end-tidal CO2, and we're also going to place that patient on, we're going to check their lung sounds with stethoscope, okay? And then we're going to secure the tube in place, okay? So ventilating the patient that's intubated, very little movement can displace the endotracheal tube. However, it does happen if you do not secure it. If you don't have a secured airway, then just assume that it got dislodged. Okay. Pay attention to resistance changes. You need to let your partner know that you've got some type of resistance changes. It's getting harder to bag or something like that. Maybe this means that we just need to suction. We may have intubated too far, or something like that. If the patient is being defibrillated, we're going to remove the bag from the tube instead of keeping that bag on there. We're just going to remove it. Watch for any changes in the patient's mental status as well, because if they start to come around and they're intubated, they're going to start trying to pull things out of their mouth, and we don't want that. Okay. With a trauma intubation, we're just going to provide inline stabilization throughout the procedure, and hold stabilization but allow for jaw movement. Okay. So we talked about these a little bit last night. Blind airway insertion devices, such as the King, the LMA, the iGel, the CombiTube. If you're older like me and have been in EMS around since the dawn of dinosaurs, you're going to look at the EOA, which is just an esophageal obturator airway. It's not used anymore, so yeah. These usually do not require the head to be placed in a sniffing position either. Okay. Alright, so chapter review. Respiratory failure is the result of inadequate breathing, breathing that is not sufficient to support life. A patient in respiratory failure or respiratory arrest must receive artificial ventilations. Oxygen can be delivered to the non-breathing patient as a supplement to artificial ventilation. It can also be administered as therapy to the breathing patient who has whose breathing is inadequate, cyanotic, cool and clammy, short of breath, suffering chest pain, suffering severe injuries, or displaying any kind of altered mental status. Hypoxia can cause the altered mental status. Okay. Things to remember. Always use PPE. Assess their breathing. Their assessment must be ongoing. Okay, it's a continual thing, just like the airway. It's not a one and done. You have to continually assess their breathing. Inadequate breathing requires immediate action. If you do not take immediate action to correct their breathing problem, then you've got problems later on down the road. Positive pressure ventilations are very different than normal breathing and can have negative side effects. We talked about those a little bit. Select the most appropriate method of positive pressure ventilations based on the patient's needs. So we talked about CPAP, we talked about bagging with a BVM, we talked about transport ventilator, anything like that. Okay. Always use appropriate safety measures when handling oxygen. Select the appropriate delivery device to provide the supplemental oxygen. So a non-rebreather mask, a nasal cannula, or anything like that. Okay, so some questions to consider I'm going to leave you with. So what are the signs of respiratory distress? What are signs of respiratory failure? For BVM ventilation, what are recommended variations in technique for one rescuer or two? Okay. How does the way positive pressure ventilations moving air differ from how the body normally moves air? And describe a patient problem that would benefit from administration of oxygen, and explain how to decide what oxygen delivery device should be used. Okay. So let's do some critical thinking. On arrival at the emergency scene, you find an adult female patient who is semi-conscious. Her respiratory rate is 7 per minute. She appears pale and slightly blue around her lips. So, is this patient in respiratory failure? And if so, what signs and symptoms indicate this? Does the patient require artificial ventilations? So let's look at it again. She's semi-conscious. Respiratory rate is 7. She's pale and slightly blue around her lips. So she's cyanotic. She is having agonal respirations. 7 is not enough to support life and homeostasis. So yeah, we're going to start something. We're going to start aggressively managing this patient. We're going to start bagging them with just a BVM is fine, and start bagging at the normal rate of 12 to 20. Okay. All right. So if you guys have any questions, let me know. You can leave those in the discussion and for this lecture, and we will get them answered. Or you can email me, text me, call me, whatever you need to do to get those questions to me. All right, well, we're all done.